Everyone, thank you so much for joining us tonight for My Bladder Hurts, Understanding Diagnosis and Management of Irritative Voiding Symptoms. We encourage you to submit your questions in the Q&A section. Today's session will be recorded and sent to all those who registered. Our speaker tonight is Dr. Nseyo. She is an assistant professor in the Department of Urology at Weill Cornell Medicine. She received her medical degree from Duke University School of Medicine and obtained her Master's of Health Science from the Johns Hopkins School of Public Health. Her clinical focus is on female reconstructive urology, including prolapse and urinary incontinence and complex voiding dysfunction, especially in a neurogenetic bladder population. She has expertise in minimally invasive and robotic techniques for complex reconstruction. It is my pleasure to turn things over to Dr. Nseyo. Thank you for being here with us tonight.
So thanks for the great introduction. It's great to be here with everyone. So as they outlined, today we'll be talking about my bladder hurts, and particularly what we call irritative voiding symptoms. These are symptoms that are usually defined by an strong urge to urinate, frequency of urination, and may be accompanied by pain. So just to give a little background about myself, I have dual training as a urologist, so someone who studies the urinary tract and the diseases of the urinary tract, things like the kidney, the bladder, the ureters, as well as the prostate. And then I also have specialty training as a urogynecologist, which means I have a specific focus on issues that are more likely to happen in female patients who have issues with their pelvic floor. So issues like prolapse, leakage of urine, and overactive bladder. I am in the Department of Urology at Weill Cornell and see patients both in the Upper East Side and in Brooklyn. So for today's conversation, we'll be looking at what we call irritative voiding symptoms, and particularly trying to get an understanding of what are the potential causes of bladder pain. Kind of related to that is, how do we determine whether your bladder pain or what you may think is bladder pain is actually related to the bladder? And then looking at the things that are most commonly causes of bladder pain or discomfort, particularly urinary tract infections, overactive bladder, and then lastly, interstitial cystitis. So typically when patients come to see me in clinic, they might tell me that their bladder hurts, and they're not entirely sure. Part of that is because of the vague nature of kind of bladder complaints, and part of it has to do with the location of the bladder. So when we look at where the bladder is located, we see that it's in the middle of the body, in the lower abdomen, so right below the pubic bone, that bone that sits in your pelvis at the front. And oftentimes people might say that pain that occurs in this general area in the lower mid-abdomen is related to the bladder. But we recognize when we look at kind of a schematic of the entire abdomen and the different organs that there are a couple other organs in this location that might mimic these symptoms. So when we look more closely at the pelvic anatomy, we get a better sense for what else is in this region that might be causing symptoms that we might tend to attribute to the bladder. So we see here that we have the bladder, but there are also bowel and intestines that are nearby in the same location where the bladder is, and often overlie the bladder. And then in women, there are also gynecologic organs like the uterus, the cervix, the fallopian tubes, and the ovaries, which are in the same general area. You can see here in this picture, they're draped kind of over the bladder. And so anytime there are issues with any of these organs, you may have symptoms that seem to be in the area of the bladder. And so we can see that in this lower abdominal section where the bladder is, you can have pain that might be due to the intestines, the ureters, the tubes that drain the kidneys into the bladder, the ovaries, or the uterus. And so this lower abdominal pain may not actually be a reflection of what's happening in your bladder. It may be a reflection of any number of conditions that happen in the same space. For example, menstruation or ovulation. It might be your appendix, especially if the appendix is not in its normal location, which is the right lower abdomen. It might be endometriosis. It might be a reflection of issues with the bowel, such as irritable bowel syndrome, where you're having cramping that might feel like it's in the bladder, but it's in the same location as the bladder. And it might be something actually due to the bladder itself. And it might be happening somewhere close to the bladder. For example, if a kidney stone gets into the ureter and it's on its way to the bladder, you might have symptoms that are generated or radiate or near to where the bladder is located. So it might be hard to tell. A condition that my patients often come to me with, where they might complain of bladder symptoms when it's not necessarily the bladder, is constipation. And similar to kind of the diagrams that looked at pelvic anatomy in general, the same issue occurs with constipation and bladder symptoms due to the relationship, the close physical relationship between the bladder and the rectum or the intestines where your stool is. So you can see here, normally you have the bladder, and this is a female pelvis, the bladder, vagina, and then the rectum. But when you're constipated, there's a lot of stool filling up the space where it wouldn't normally be. And so this puts a lot of pressure on the vagina and the uterus, and also the bladder. And so patients might have lots of bladder related symptoms, but really the true root cause is the constipation. And when we assess and identify that they have bad constipation and treat that constipation, we find that their bladder symptoms, this bladder pain and cramping and discomfort, actually gets a lot better. So it's really important when we as specialists evaluate patients who come to us with bladder pain, or when a patient might think, oh, my bladder hurts. It's really important for us to kind of drill down and determine, is it really the bladder, which can be difficult to determine because of all the other organs that are in that same area. But we use a combination of our physical exam skills, and the questions that we ask patients about their symptoms, and if necessary, imaging to give us a better sense of what in that lower abdomen might be actually causing these symptoms. And if we do find that it's unrelated to the bladder, that's when we have the opportunity to treat what that underlying root cause is. For example, if it's constipation, a ureteral stone, some issue with a gynecologic organ, and either manage it ourselves if we're able to do that, or refer the patient to the appropriate specialist. So I think that's the first part of identifying bladder pain, is making sure that it is in fact related to the bladder. If after we've done kind of all this assessment and determine that the bladder is in fact the source of the bladder pain, then that's when we start to figure out what is it about the bladder that's causing these symptoms. I think a good place to start is to get a better sense of what the bladder is and what it does. So the bladder is an organ, as we mentioned, that sits in the pelvis. When the bladder is empty, it's about the size of a pear. And when it's full, it typically holds about 2 cups of urine, or about the size of a softball. So the bladder holds a really important function, fulfills a really important job in the body. It has 2 big roles. One is to collect and store urine that comes from the kidneys. So the way that your body kind of gets rid of the waste through the kidneys is that the kidneys filter and then create urine, and that urine goes through the tubes called the ureters that connect the kidneys to the bladder, and then the bladder serves to collect that urine. And then when it's time, when the bladder is full, the job of the bladder is then to empty and get rid of all the urine that it's been storing at an appropriate time. And that decision about appropriateness is really based on what feedback the bladder is getting from the brain in terms of whether this is a good time. When the bladder is also a muscle, and so when it's filling, it's relaxed, and that allows it to fill appropriately and hold a decent volume of urine. And then during urination is when it's acting as we typically think of muscles, and contracting and squeezing to get out all of the urine inside of the bladder. The bladder also serves an important role in terms of its communication with the brain. Part of this whole reflex in terms of emptying the bladder completely is really dependent on the communication between the brain and the bladder in terms of determining when it's an appropriate time to urinate. So when the bladder gets full, it sends a message to the brain telling the brain that it's time to urinate, or that the bladder is full and senses that it's time to urinate, and then the brain then sends a message back to the bladder to let the bladder know whether or not this is an appropriate time, and if not, it suppresses this urge that you feel to urinate, where you are able to control that urge to urinate, and then you know, gives you kind of the ability to urinate when it's an appropriate time. And so that's how your bladder, under the control of the brain, is really able to determine when it is or is not an appropriate time to empty. And so this coordinated process of voiding requires not just the bladder, but also the pelvic floor muscles in order to make sure you empty your bladder appropriately. So once the bladder receives that final message from the brain saying that it's an appropriate time to empty, that's when you have this kind of coordinated activity working hand in hand between the bladder and the pelvic floor, where the bladder squeezes and then the pelvic floor relaxes, so that when squeezing, the bladder actually empties, and so that the pelvic floor or the sphincter, the muscles that are helping you stay dry, relax so that you can empty all the way. And so whenever there's an issue with any of these stages, either the bladder filling appropriately, or the bladder storing urine, or the bladder emptying well, that's when you can have issues with the bladder that can develop into either leakage of urine or any of these kind of bladder pain issues or voiding symptoms that we're about to talk about. So sometimes patients will come to me and say, my bladder hurts and I need to pee all the time. And so when you get a complaint like that, there are a couple of things that are running through my mind in terms of what this might be. And when I think about, ruling things out, I always want to rule out things that are acute or might be, potentially dangerous to the patient first and foremost, before and make sure those aren't what's causing these symptoms. One of the things that we initially start to think when a patient comes to us saying that they have some pain in the bladder and they're peeing frequently is a urinary tract infection. So when someone says, I think I have a UTI, I think I have a urinary tract infection, I think I have a bladder infection because I'm having these symptoms, we are always thinking about other things that might be causing these symptoms, things like constipation, a stone in the bladder or the ureter, inflammation of the bladder without infection, a condition called overactive bladder, which we'll talk about more, and last but not least importantly, bladder cancer. And so I'm sure many of you are familiar with kind of the typical symptoms that patients might have, or that you might have when you have a UTI or bladder infection. Patients might notice that their urine is cloudy or foul smelling. There might be blood in the urine. They might have pain in the lower abdomen. They might have the sensation like they need to urinate but aren't able to. They might have pain or burning when they urinate. They might find that they're urinating more frequently. They might have pain with activity or sexual activity, and they might feel sick, tired, fatigue, just kind of overall crummy. And so the real key for us is determining if these symptoms are in fact due to a urinary tract infection. And the way we do that is through paying attention to a couple of things. As I mentioned earlier, when we were talking about just lower abdominal pain in general, it's really important for us to get that history from the patient, because that will help us determine whether or not this is truly a UTI or bladder infection. We want to ask patients about their symptoms, when they started, how long they've been going on, and if there are any associated factors. The timing is really important. Usually UTIs are pretty acute. in terms of their symptoms lasting for a couple of days, sometimes a couple of weeks if they haven't been caught. But it's rare. It is not a UTI if someone comes and says, "Oh, these symptoms have been going on for a year," right? So those are questions that help us kind of better define what's going on. We also do a physical exam where we're going to look for any abnormalities. We're going to make sure that the bladder is emptying well, because that might lean us one way or another in terms of symptoms. And then we're going to do a test of the urine, because that's going to really be our key to determining whether or not there's a true urinary tract infection. So when we talk about urine testing, there are 3 ways that we test urine with kind of different time frames in terms of how soon we're going to get information from them. The quickest of these is the urine dip. This is our quick and dirty test that we're doing in the office when we first see a patient. This is the test that, a lot of these home UTI kits utilize the same technology, where it's just giving you a general sense of urine abnormalities based on the color change in a paper test strip. So it's not very specific in terms of, it's not giving you kind of really detailed information, but it's giving you a general sense based on that color change of what might be in the urine. The one drawback of this test is that it's not very specific, in that there can be other reasons why different values show up that may not necessarily be due to a true infection. The kind of next step in terms of a more definitive or specific test is a formal urinalysis with a microscopy, where you're taking the urine and looking at it under the microscope. And this allows us to determine the number of cells and the types of cells that are in the urine. And so that gives us an even better sense of whether or not there's a high likelihood of infection. We'll be looking for things like presence of bacteria, presence of white blood cells, leukocytes, which is the byproduct of white blood cells, nitrate, which is the byproduct of bacteria that are typically a cause of these urinary tract infections. So this will allow us to get a better blood in the urine under the microscope. These will all be things that we're looking at to say, oh, what's the likelihood that this patient has an infection? And this information you get back, relatively quickly. The most definitive test and kind of our gold standard in terms of saying, okay, this person definitely has a UTI, is a urine culture. So this test takes the longest to get information back from, because it requires that you're taking the urine and growing it on a plate in the lab, so that you can actually see what bacteria are growing from the urine. And so this is the test that we use to definitively say, okay, yes, you have a UTI. And then it also, not only does it give us information about the bacteria, but it also gives us information about what antibiotics can be used to treat that specific bacteria. And so when we are making the diagnosis about a UTI, it's important to both have the symptoms, but also have a urine culture that shows significant bacterial growth. And specifically bacterial growth for a bacteria that we know causes UTIs. There are normal bacteria all throughout our body, in our intestines, in our vagina, in the bladder itself. And so we also want to make sure we're treating bacteria that actually cause an issue or actually cause infection. So we use the term UTI, urinary tract infection, and typically we're referring to a bladder infection. But it's important to note that a UTI can occur, as it's truly defined, a UTI or urinary tract infection can occur anywhere throughout the urinary tract. That means the urethra, where it's called urethritis, the bladder, where it's called cystitis, or the kidneys, where we call it pyelonephritis. For the majority of patients, they're going to be presenting with either urethritis or cystitis, where they might have kind of low-grade symptoms and not really have much in the way of systemic symptoms in terms of fevers, chills, etc. And more often than not, when patients are having pyelonephritis, they'll be much sicker than your standard, bladder infection, with fevers and chills and pain on the side of the kidney. that's hurting. When we know that, bacteria is the cause of these infections, but how does it happen? The process of a UTI really happens based on the bacteria making their way into the urinary tract. We know this is much more commonly occurring in women because of our anatomy, with our shorter urethras and also the short distance between the GI tract and the urethra. And so it's much easier for women to get urinary tract infections than men, but you can see the bacteria are able to travel up the urethra and then start in the bladder. And that's why we say that all infections kind of start in the bladder. And then depending on the type of bacteria, some are then able to crawl up into the ureters and make it all the way to the kidney, and then cause a kidney infection. The majority, though, of UTI, bladder infections, though, don't make their way to kidney infections. And oftentimes, patients who have, recurrent kidney infections may have some anatomic reason or some abnormality in their urinary tract that's putting them at risk for this. So, say we've evaluated a patient, we determined that they don't have a UTI, then we might be wondering, well, what else could it be? If they're having, discomfort in the lower abdomen, they feel like they're having these what we call irritative symptoms where they're running to the bathroom all the time or feeling like they need to pee all the time. What else could they be dealing with? And so patients might say, I feel like I'm cramping in my bladder. I need to run to the bathroom to pee all the time. What's going on? They've checked me. I don't have an infection. What else could it be? And the next likely possibility is a condition that we call overactive bladder. So overactive bladder, oftentimes people who have overactive bladder might, tell people, oh, I've always had a small bladder or I have a sensitive bladder. And oftentimes these are symptoms that have been going on for quite a while. And it's predominantly characterized by a patient or an individual who feels like they need to urinate with a strong urge. When they feel like they need to go, they really, really have to go. And they aren't really able to delay or suppress the urge successfully. It can also be accompanied by urinary frequency, so going to the restroom frequently, every hour, hour and a half. And you may have leakage associated with that urge where you have a strong urge, you're unable to, not only are you unable to suppress the urge, but you're also not able to make it to the restroom in time before you start urinating. You might have urinary leakage or urinary accidents. So, as we discussed, under normal conditions, the bladder is able to fill with what we call a normal volume of urine, which is usually 300 to 400 cc's, or about a softball size bladder of urine. And then through a coordinated event between the brain, the bladder, and the pelvic floor, the bladder is able to empty. But the problem with overactive bladder is that the bladder isn't storing like it's supposed to. So instead of the bladder sensing that it needs to urinate when it's actually full, in overactive bladder, the bladder is sensing that it needs to urinate when the bladder isn't completely full. So typically when this is happening, it's almost like the bladder short circuits, right? Instead of fulfilling that full communication arc where it fills to a full volume, sends a message to the brain, waits for the brain to tell it that it's time to go to the restroom, the bladder short circuits and it's trying to squeeze and empty before it's even gotten a message up because it's not full yet. So oftentimes individual will know that they find that their bladder doesn't give them enough time. They feel an urge and it's like the body's already going before they even have time to get anywhere. They're urinating before they even realize it sometimes, and they feel like they're constantly rushing to the restroom just because that time frame between the notification that the bladder needs to go and when the bladder starts going is just so short. And so, our studies have shown that there are kind of two mechanisms, two ways through which this can happen. It's either happening because it's a sensation issue, right? The bladder, like we talked about earlier, the bladder is both a muscle and kind of its own little brain where it gets sensation from nerves and send messages to the to communicate to the brain via nerves. And so sometimes it's the nerves that are sensing that the bladder is full, even when it's not. And so the nerves are sending a message saying, oh, it's time to go, it's time to go. Other times it's the bladder muscle itself that's having a contraction before it's completely full. And then that's causing the urinary leakage. Either way, whether it's through kind of sensation in nerves or through contractions in the muscle, these conditions can cause, the bladder discomfort and be associated with these irritative voiding symptoms. And the management in terms of how we approach them is similar, regardless of whether it's the nerves or the muscles that are causing the bladder to sense that it's full when it's really not. So, when we counsel individuals about managing these overactive bladder symptoms, we always start with kind of what we call conservative treatment options, things that are relatively easy for for an individual to implement on their own. So we talk about dietary modifications. We know that bladders that are overactive are really sensitive to bladder irritants, things that we know can make the bladder more likely to spasm, like caffeine, alcohol, chocolate, spicy foods, essentially all the good things. But we know that bladders that are sensitive are more likely to respond negatively to these things and make the urgency and frequency even worse. Oftentimes, we also find that patients who have overactive bladder will try to take on different activities or change their behaviors in a certain way to actually reduce the amount that they urinate in an effort to reduce their frequency. And in limiting their fluid intake, they're dehydrating themselves and they're actually making the overactive bladder worse, because instead of, while they may be actually, reducing the amount they urinate, they're also making the urine more concentrated. And as we talked about earlier, the urine that we produce is waste. It's what the body wants to get rid of. And so you can imagine if it's more concentrated, there's more waste and less fluid. And so that can also irritate the bladder more. So it's actually staying well hydrated that actually has a better impact on these symptoms than avoiding fluids altogether. There are also actions that can be taken around the time of urination that can help to improve these symptoms, like bladder retraining, where you try to learn to go before the urge comes. Toileting habits, making sure you're not rushing, hovering, taking time and relaxing when it's time to urinate. And then also pelvic floor physical therapy and muscle strengthening and using your pelvic floor muscles to both help strengthen and support the bladder, but also to help train the bladder to kind of turn off when you're having a strong urge. There are also medications that can be used in combination with these kind of lifestyle changes, or, in addition to, if these lifestyle changes don't make a significant impact. And then lastly, we have, procedural treatments that can help address the bladder, either sensation or the nerves to the bladder, to improve the ability of the bladder to hold urine fully and empty at a normal time. So if we've evaluated patients and we've ruled out an infection and there are symptoms that are similar to overactive bladder, but they have more of a pain component, that's when we start thinking of a condition called interstitial cystitis, where patients will often complain about feeling like they need to urinate, they have a pain in their bladder, but they've been evaluated several times and there's no evidence of infection. So interstitial cystitis is defined as a chronic, long-lasting condition that causes painful urinary symptoms. When we look at the bladder, we know that there's significant inflammation in the bladder in these patients. They may also have associated pelvic pain in a way that's kind of related to the bladder itself. And it's what we call a diagnosis of exclusion, meaning that it's a diagnosis that we arrive to after we've ruled out that there's nothing else going on. So it's a diagnosis that we come to after we've made sure there's no evidence of infection, there's nothing else in the lower abdomen that might be causing these symptoms. There's no evidence of stone, cancer, foreign body, or anything else that might be causing these bladder pain and irritative voiding symptoms. And once we've done that, that plus the kind of the chronic nature of these symptoms of, at least 3 months, then we can say, okay, this person is likely to have interstitial cystitis. And so I think the diagnosis of interstitial cystitis really highlights the importance of making a clear diagnosis in terms of, what symptoms we're dealing with, and to truly identify what might be causing this bladder pain or discomfort. We can see here in this Venn diagram that there's a lot of overlap between overactive bladder, interstitial cystitis, bladder pain syndrome, or chronic pelvic pain syndrome. And so, you may have patients that have a little bit of each part of these symptoms, and it's important to use our diagnostic skills as clinicians in order to determine what the true diagnosis is and to make sure that we can help our patients appropriately. And so, we oftentimes see patients that have a little bit of overactive bladder, but also have some components that are more like IC. And so, we are always working to kind of tease out what symptoms fit in which bucket so that we can help our patients as much as possible. And so we've really kind of expanded how we think about IC. Before, we used to only think of it in terms of patients who have pain with bladder filling, that gets better with bladder emptying, and have, urgent, frequent urination. But now we have, really broaden our understanding of this condition and know that there are kind of different, what we call phenotypes, different ways that patients may present that fit under this interstitial cystitis bladder pain syndrome umbrella. So we have, we might find patients that have, much more pelvic floor driven symptoms where, they might have urgency frequency, but when we examine them, they have a lot of tension in their pelvic floor. And so they might benefit more so from pelvic floor physical therapy and aren't necessarily as responsive to treatments that are focused on the bladder or bladder lining, or don't necessarily find that the foods that they eat or drink really impact their bladder. We also know that there are patients who really just have really bad urgency frequency that is, quite debilitating, and it keeps them up at night and doesn't allow them to really function, and don't have much in the way of pain, but just have this constant kind of urge to urinate. Some patients might have more urethral pain, focus symptoms where there's pain just with just pain in the urethra. And just might have more pain with sexual activity. And then we also know that there's a big overlap between interstitial cystitis and other kind of pain syndromes throughout the body, things like fibromyalgia or regional pain syndromes. And so we also know that there's some patients who are just what we call hypersensitized, where all their nerve endings are kind of turned on and firing all the time. And so they might do better with a treatment regimen that addresses kind of general overall pain levels. And then we know that there are patients who have kind of more of our traditional IC, where they have, bladder inflammation. They might have lesions in the bladder that suggest inflammation. And then we also know that IC can develop, interstitial cystitis can develop after the onset of an infection, where we have patients who have had a UTI, a bladder infection, a urethral infection, and then have these persistent lingering symptoms that are ongoing for a while after that, and might, coexist with kind of recurrent infections. But I think, this big umbrella, this improved understanding, is important not only for us as clinicians, but also in terms of helping our patients better understand, what might be driving their symptoms. So when we look at a bladder that has interstitial cystitis, we commonly will see what we call glomerulation. So patients might say, oh, someone did a cystoscopy, a procedure where they looked inside my bladder with a camera and saw that there were these findings that, led to a diagnosis of interstitial cystitis. Again, that finding by in and of itself does not necessarily mean that they have interstitial cystitis. As we've highlighted before, it's important to link any kind of finding with symptoms, but this is something that's commonly seen. And so, our general theory about interstitial cystitis is that it's an issue with the bladder wall lining in terms of the kind of the classic understanding, where someone has predominantly bladder focused symptoms, where there's thinning of the bladder lining. And so then the bladder is kind of more permeable. You can think of it almost like allergies for the bladder, where the bladder is now more sensitive to things that are commonly occurring, like urine, caffeine, carbonated beverages, milk. And so you might find that there's an increased sensitivity to the bladder lining. And sometimes with that thinning of the bladder wall, patients can develop ulcers, where you'll actually see on cystoscopy, when you look inside the bladder, that there are ulcerative lesions in the bladder that might respond specifically for treatment. And so similar to the way that we approach overactive bladder, we are always looking at conservative treatment measurements for interstitial cystitis and bladder pain syndrome and chronic pelvic pain, where we recognize that because there's so much overlap in terms of these symptoms, it might be that it might not be a one hit in terms of treatment, and it might require that we're using kind of what we call a multimodal approach, where we're looking at different treatment options and tackling it from a lot of different vantage points. So when we think about conservative treatments, we know that these are actually quite successful, because there's a lot of kind of social and environmental and psychosocial aspects that contribute to interstitial cystitis and chronic pelvic pain syndrome. So we know that diet is really important. Again, we know that similar to overactive bladder, there are certain foods and drinks that are more likely to irritate bladders in patients who have interstitial cystitis. We know that stress management is incredibly important. Oftentimes, patients will talk about how a certain stressor, or when they're stressed, they're more likely to have a flare of their symptoms. And we know that this relationship between stress and the bladder is seen not only with interstitial cystitis, but also with overactive bladder, where patients might find that when they're in the stressful situations, they're more likely to have this urgency frequency. And so we know that things that help you manage your stress are really important. Mindfulness, meditation, exercise, sleep, taking baths, yoga, massage, anything that are stress relievers go a long way in terms of addressing the symptoms of interstitial cystitis. And then, beyond these conservative treatments, we have medications that can help address the pelvic floor or the bladder, procedures that focus on the bladder or the pelvic floor, and then also surgeries that help to kind of regulate the nerves to the bladder and pelvic floor in terms of managing these symptoms. The most important caveat with all of this is that if you're having any of these symptoms that we've discussed and you see blood in the urine, you should see a specialist. It is not uncommon to see blood in the urine with infections, with a bladder infection or UTI. It's not. Some patients with interstitial cystitis might see blood in the urine, either that they see visibly or under the microscope. We might see blood under the microscope with overactive bladder. But it's important to note that the blood in the urine is not something that should be thought as common to any of these, and should definitely warrant further investigation. So, in conclusion, when we're thinking about reasons why your bladder may hurt, or why you might be having pain in your lower abdomen, first and foremost, it's important to recognize that it may not always be the bladder. Working with your physician, you'll be able to tease out whether or not these symptoms in the lower abdomen are actually related to the bladder, or if there might be some other cause. As we've kind of highlighted through our discussion of all of these different conditions, diagnosis is key. So, all of these, what we call irritative voiding symptoms, there's overlap between all of the conditions we've talked about today: overactive bladder, urinary urgency, pain with urination. And so, as you can see, it can be any of the conditions that we've talked about: overactive bladder, urinary tract infections, interstitial cystitis. And so it's really important for us as clinicians to clearly diagnose, or try our best to clearly diagnose what's going on, so that we can help patients find a resolution. And sometimes it's challenging, as you saw in that Venn diagram for interstitial cystitis. There might be overlap in terms of whether there's overactive bladder symptoms with leakage of urine, interstitial cystitis symptoms, not to mention that you can also have a urinary tract infection with a lot of these symptoms. And so, you know, really paying attention to when these symptoms occur, the timing, and other evaluations that we can do to help determine what the likely diagnosis is really important in terms of making sure that we're able to guide patients to the appropriate treatment. And then, when in doubt, you can always see a specialist. It is not your job to determine if it's your bladder that hurts. That's our job. So it's completely reasonable, and I see many patients just come to me and say, "Hey, I think my bladder hurts," and then it's our job to kind of work through that with you to determine whether or not it is your bladder, and what we can do about it. So here's information on our clinic at the Center for Female Public Health, and we encourage you to reach out if you're having any symptoms or concerns, and schedule an appointment to see us. And I think this is a great time to take some questions.
Thank you so much, Dr. Nseyo. I'm just putting the phone number in the chat. Can you just go back to that
Yeah,
last
of course.
second, just so we can keep that up for everyone?
Yeah, yeah,
Um,
happy to.
Perfect. Okay, so we have a bunch of questions that came in here. So someone is asking, does a prolapsed uterus cause urinary incontinence? I was told to do Kegel exercises, but it's not helping.
Yeah, that's a great question. So I didn't get into the kind of myriad of causes of different pelvic floor complaints. Prolapse is definitely something so let's broaden a little bit. So there are two reasons why we as women can leak. One that we talked about is overactive bladder, where the bladder is spasming before it's supposed to and causing you to leak urine on the way to the restroom. The other reason why we leak is called stress incontinence, where you're going to leak when you cough, laugh, and sneeze. And that's more of an issue with pelvic floor support. So the short answer is that prolapse does not cause urinary incontinence, but prolapse is often associated with urinary incontinence because they work through similar mechanisms. So people with prolapse may have either urge incontinence, the kind of incontinence that's associated with overactive bladder, or stress incontinence, that the leakage is happening with cough, laugh, and sneeze because the pelvic floor isn't well supported. And so those two just tend to go hand in hand.
Someone else is saying, sorry, I'm just trying to reword this to keep everyone's privacy. Someone is asking, will issues with the bladder affect the kidneys? They've been dealing with this issue for over a decade, and they're concerned about their kidneys in general.
Yeah, so most of these, great question. So most of these irritative voiding symptoms that we've discussed won't damage the kidneys. We start to worry about bladder issues damaging the kidneys when the bladder isn't emptying well or isn't emptying completely. Sometimes when that happens, it can put pressure on the kidneys, or just the act of not emptying the bladder all the way can cause backup in the kidneys, and so that might impact the bladder. But things like overactive bladder, UTIs, as long as they're infections confined to the bladder, interstitial cystitis don't tend to impact the kidneys or cause any kidney damage.
Someone else is saying that when they use the restroom, they're not able to release all of it. They have to strain, and often have to go back, a moment or two later. what's causing that?
Yeah. So the short answer is
Very
there are
annoying,
lots
by the
of
way.
there are lots, it is very annoying. There are lots of things that might be causing this. Um, we didn't really talk about incomplete bladder emptying or not emptying your bladder completely. So sometimes patients when the individuals are experiencing this urinate and they feel like they need to go back soon after, it can be that they didn't empty completely. A lot of times that might be due to just toileting habits where they're either in a rush or they're not giving themselves enough time to fully empty their bladder completely. If that's happening where you feel like you finish and have to go back soon after, we often recommend that patients, the individuals wait a little bit and then try to relax, not push or strain, but try to relax their pelvic floor to help them empty better as a means of getting everything out. But there are any number of reasons why it might be hard to urinate. You might have a blockage in the urethra, you might have prolapse, you might have issues with the pelvic floor that make it hard for you to relax. But yeah, any number of things that might be causing it, though. I would recommend you come see us and we can help you figure it out.
And this is a great question that came in. Which test checks if the bladder is inflamed?
Yeah, that's a great question. So there are a couple tests that give us some information about the general state of the bladder. So a basic kind of urinary test, a urine test with microscopy, where we're looking at the urine under the microscope, can give us information about whether there's inflammation in the bladder. If we're seeing, we call it pyuria, it's like our formal term, but if we're seeing signs of inflammation or infection, but not seeing any of the other indicators of infection, so we're not seeing nitrites, we're not seeing bacteria, we're just seeing kind of white blood cells and leukocytes, that's an indication of inflammation. As I mentioned, a cystoscopy, which is typically an office-based procedure where we look inside the bladder with the camera, we'll see changes to the bladder wall that look like that are consistent with or indicative of inflammation. Occasionally, we may get a biopsy if we think we're particularly concerned or something looks abnormal, where we take a piece of tissue from the bladder wall, and that will give us additional kind of that tissue diagnosis of inflammation. But when we're talking about inflammation in the sense of interstitial cystitis, oftentimes we're first basing the diagnosis based on the patient's symptoms, and kind of proceed to doing confirmatory testing, whether it's a cystoscopy or a biopsy, if they don't respond to initial treatments, and we want to make sure that our initial diagnosis is correct.
Someone else is asking, does your menstrual cycle, can it cause pain in your urethra?
So good question. So the just menstruation by itself can't cause urethral pain. There are some conditions where there might be a relationship between menstruation and bladder pain, or urethral pain or discomfort, for example, endometriosis, where there might be implants on or in or close to the bladder, can cause kind of these cyclical periods of urethral or bladder pain that are related to your menstrual cycle. But typically, just by itself, menstruation doesn't cause urethral pain. The one caveat though is that we know that, throughout the menstrual cycle, there are changes in hormone levels, and we know that changes in vaginal hormone levels can impact the balance of good and bad bacteria. So sometimes we find that patients will note more urethral irritation or discomfort during periods of their cycle, that might be related to kind of the balance of good and bad bacteria in the vagina.
Someone else is asking, they said they've been using antihistamines with positive results. Have you seen success with this for IC?
Yeah. Definitely. Yeah. So I didn't go into details in terms of the medications that we use for IC, but antihistamines are one of the medications that we prescribe. If you remember from the diagram in terms of the umbrella of IC diagnosis, there's like an allergy IC sliver of that big wheel, and so we know that there are patients that respond well to antihistamines, and so yeah, that's definitely an avenue of treatment that we've found to be successful in patients.
And another good question that came in is how much water should we be drinking to avoid dehydration, but not be running to the restroom every 3 seconds?
Good, good. So first and foremost, we know that the amount of water that everyone drinks is specific to that individual. So it depends on where you live, the climate, how active you are. Our general recommendation is 6 to 8 glasses of water a day. And kind of titrating that based on your level of activity. If you're running every day, obviously you need more. If you work, outside, if you live in the desert, things like that, you'll definitely need more water versus less.
Someone else is asking if I don't want to get a urodynamic test, what are some alternatives?
Oh, okay. So not we didn't talk about this, but just for educating the group, a urodynamic test is a test that we do to help us understand more about how the bladder functions, and understand any abnormalities somebody might be having with urinating or emptying their bladder or any of the urinary symptoms. So in terms of other tests, it's hard. It's a hard question for me to answer without knowing exactly what the indication is for the urodynamic testing. Um, Typically, if we're doing it, it's because there's a certain question that we're trying to answer. There are different parts of it that we might be able to pull out. For example, we can do a uroflow, which is the first part of the urodamus, where we just see how you empty your bladder. We don't use any catheters or anything, but we just see, what the flow looks like when you empty, and that can give us a little bit of information. But truly, if we're trying to understand how the bladder fills and squeezes when you're storing urine and voiding, the urodynamics is really the kind of the best test to do that.
Someone else is asking, do vaginal moisturizers help urinary urgency symptoms?
Yeah, great question. So we know that when we as women get older and there's less estrogen in the vagina, it changes not only the vaginal tissue, but also the urethra. And so a lot of times those irritative symptoms, the urgency, frequency, a little, small bits of leakage are actually helped by treatments that focus on changes that happen to the urethral and vaginal tissue. Vaginal estrogen, low dose vaginal estrogen is always a great option. It doesn't get absorbed in the body. And so it just works locally in the vagina. So it doesn't have some of the health concerns that are attributed to estrogen when taken as a pill or a patch. But vaginal moisturizers, non-estrogen based vaginal moisturizers, also help address some of those tissue changes. And there's some good ones that we like that really help improve the quality of the vaginal and urethral tissue and can help with some of these irritative urinary symptoms.
So just to let everyone know, I see that there's a few questions here. Some of them are extremely specific, to you and your scenario. And there's no way for Dr. Nseyo to kind of answer them without seeing you, being able to run her own tests, based on all the specific information that you're providing. So please don't feel that we're ignoring your questions. It's not the kind of thing that we can answer with no additional information. So someone here is asking, have you found neuroproliferative or hormonally medicated vestibulodynia? I don't know.
Mhm.
You can see in the Q&A, that's the culprit for bladder pain?
Oh, yeah. So I
Mm.
vestibulodynia, not necessarily. I think more often than not, actually, I mean, so there's, I talk generally about kind of diagnosing interstitial cystitis and uh, chronic pelvic pain syndrome, but there are kind of more nuances to the diagnosis in terms of where the pain might be located. And we actually find more often than not in our patients that a lot of these symptoms, whether they're urethral, vest, localized to the vestibule, vaginal, bladder related. A lot of them are kind of related to the pelvic floor, where we're finding that patients have a significant degree of pelvic floor muscle dysfunction, with what we call trigger points, where when we press on these certain muscles, they recreate a lot of their symptoms. So they might recreate their bladder urgency, or might recreate this vague lower abdominal discomfort that they kind of relate to their bladder. And so we often find that addressing the pelvic floor goes a long way in terms of addressing a lot of these symptoms. There are, you know, treatments that are specific to the vestibule, to vestibulodynia, but not all IC kind of fits into that bucket.
And then we have time for one more question, I think. Someone is asking, what are your thoughts on probiotics for people with UTIs? They've heard mixed
Oh,
things.
I love them. I love them for many reasons. I think oftentimes patients who have had UTIs, especially if they have recurrent UTIs, they've been on a lot of antibiotics, and while antibiotics are great for treating UTIs, I'm not saying that we shouldn't treat UTIs with antibiotics. They also aren't very specific. As I said earlier, our body is full of good bacteria that we need, and so antibiotics will get rid of good bacteria in our gut and in our vagina. So I'm sure patients can attest to getting, diarrhea from antibiotics, or getting a yeast infection every time they get antibiotics. And for women specifically, the vagina is a really important kind of way station for preventing against UTIs, because the vagina is where you're gonna have the bad bacteria that end up getting into the urethra, where they hang out, as well as the good bacteria. And so we know that just important, to getting rid of the bacteria in terms of preventing the infections, is making sure that there's a good balance of good bacteria in the vagina, so that the bad bacteria, which we know naturally live in the vagina, aren't overpowering the good bacteria and making it easier for them to get to cause a UTI or infection. So when we treat or look at preventing UTIs, we often recommend probiotics, either orally, or vaginally, like a vaginal suppository, and specifically probiotics that are focused on repopulating the good bacteria in the vagina, the lactobacilli, specifically, and using that to make sure that there's good bacteria to prevent the recurrence of UTI. So I'm a huge fan. You just have to make sure that they're the appropriate amount and specific to repopulating the vagina.
Perfect. Dr. Nseyo, thank you so much for your time tonight. We so appreciate it. To all of the people who joined us tonight, thank you. We're so happy to have you here. I'm sorry that we couldn't get to all of your questions. There's just so many coming in. But we're so happy to see everyone so engaged and asking such great questions. As we mentioned, for those of you who had really specific ones, I'd highly recommend booking an appointment so that your specific needs can be looked at with, the full picture of information. And tonight's recording will be sent out to everyone who registered in the next couple of days. We'll also include the phone number as well as the location, so it's easy for you to make an appointment. We thank you all for spending your evening with us, and we hope to see you again soon with some more content. Thank you, Dr. Nseyo. Have a great night.
Thanks, everyone. Have a good evening.
Good night, everyone.
Bye.